Right about there. Perfect. And we are good.
Good.
Okay. We're on.
Hey everybody, Jake with the Central Motion Spine Sport.
Good afternoon. How's everybody doing? This is what, Wednesday?
Wednesday.
Day after election day. Everybody's doing great. We wanted to come with Chris, by the way, physical therapist, also your owner and creator of the Herniated to Healthy Disc program, along with the Executive Health Solutions, physical therapy, chiropractic. So we wanted to come on again today and talk about more things, herniated disc, and we kind of went away from that a bit, did some ankle stuff, we did some shoulder stuff, a couple ankle ones, yeah. But let's get back to what we see the most often, and the questions that we answer the most often, which would be, for this one, the number one myth that people believe about having a herniated disc, and that myth is that when people hear, "Ooh, my disc is herniated and I have this, this problem like that," that it is not fixable without surgery. That it will not heal. It's there permanently. It'll never go away. And we get that question often. And here's what we can tell them. We can safely tell them with science. We don't do the research. We just read it, and the research is there. That what happens with these kind of things.
Yeah. So the majority of cases, I think, what's the number we usually see? Like somewhere between 90 and 95%. Can respond to conservative treatment, so you don't need surgery.
And do heal.
Yeah, and they do heal on their own. Yeah, so when you have this herniated disc, okay, part of that nucleus, that inside material, kind of presses out and can injure that nerve or press onto that nerve. Nerves don't like to be compressed.
Make sure that's really on there.
Yeah.
That's a good model. Yeah, you're showing it perfectly.
Perfectly?
Yep. Stay right there. And turn it just a little bit more to the, keep going. There, you can really see that little red piece of tissue there, poking out and irritating that nerve, that yellow spaghetti. Should actually come closer, Jake. It's really, there we go, right like that.
So that's what can cause that pain, not only in the back, but even going down the leg, the sciatica that many of us, are familiar with.
So this tissue here is called the annulus, okay? The annulus is the cross-like fiber, the thickness that holds the nucleus in, right? Now, there are nerve endings on the annular wall. So if you have an injury to the disc, you can have what's called discogenic, just meaning originating from the disc, like anything, like genesis, the origination, the origin. So if you have disruptions here, you can have just back pain and just pain coming from the disc, or with certain things, as that thing starts to move and bulge, takes up space it doesn't belong in. If it's enough space and enough irritation, it can irritate that yellow little spaghetti strand looking nerve root thing, and then you'll have some pain that can go down one leg, it can go into the front, it can go into the side, into the back, sometimes into the calf, the foot.
Yeah.
Right? So just, you see how the different levels? It depends on what level your problem is at, and you can easily tell where that injury is coming from without the use of the expensive, advanced imaging tests like MRIs and stuff, because our bodies are built in a way that we have what are called dermatomal and myotomal patterns, right? So where that nerve goes, we're all built the same way. So if this nerve is at the L, if this is L, so when you have your test and they say, yes, you have a bulge between, L4 and L5, that's what that means. That disc right there, or this bone is lumbar number 4, so L4. This bone is lumbar number 5, and they're talking about the disc between the two. So it could be 3, 4, it could be even higher, 2, 3, or it could be 5, 1 on top of the sacrum. You can't see the sacrum, but it's down there. Yeah, there'd be another disc between that one.
Yeah.
So that's what it means when you see those kind of funky terms of, I got a disc bulge, it's 4 or 5.
Yep.
But those are dynamic, movable tissues, and they can reduce and move back in like that. That's actually a really good model. You can see that taking up space. I think it makes sense to people when they can see it mechanically, because they actually feel it. So think about that. When that thing is taking up that space like that, that's why when you try to bend forward and it pushes it further in a way that hurts. That's why when you try to bend backwards or to the side, it's actually it's in the way. It's taking up space. So you can't go back. You feel obstructed with your motion.
Right, you cannot bend
back. It pinches and it hurts. But there are ways that Jake, with specific movements and specific techniques, that chiropractors and physical therapists use to help reduce that and move that back out of the way, Now, the other way would be, of course, surgery to clip that off there.
Yeah.
That's one way. And for some, it is faster and it is necessary. But for many, you don't need to do that. With time and the correct treatment, you can get that to reduce and then heal back here with some scar tissue. And now all of a sudden, when you got that thing there, now when you push that out again, it holds and it doesn't allow that thing to come back in, occupy space.
Exactly.
So that is the biggest myth that people back up just a little bit more. There we go, right there. Right there. Yep. I just want you to get your head cut off on that. That's the biggest myth that we find. That we answer to people. Oh, I have a herniated disc. I have to. Do I have to have surgery? Do I have to?
You do not. You don't need surgery. You're going to recover for the most part. Everything's going to go very well with conservative care. And most of the time, our body is very good at healing these anyway. Over time, even if you had no treatment, granted it might take longer than if you were to receive treatment.
Be very uncomfortable with.
Our body has macrophages. They come in and they'll eat up that material. They recognize this as like an invader. That should not be there. We need to get rid of that. So it just takes time for the body to send in those little macrophages to eat that up piece by piece until it can resorb on its own.
Shrink it down. Yeah.
Right. So
that's just the way we even call it. Like we call it a derangement. All it means is that there's a tissue occupying space it doesn't belong in. Our body, which you say our body even recognizes that as being foreign and like, oh, you're not supposed to be there. And actually, there were some studies done too that the bigger and badder it is, like ones that actually like where it goes through the annular wall and it just like spews out, they actually heal faster than the ones that don't, because your body recognizes that this is a serious thing. Let's take care of it.
Nice.
Very interesting.
Yeah. So just because you have a diagnosis of a herniated disc, or just because you have a picture of it, doesn't necessarily mean that you're bound for a lifetime of pain, because that's definitely not the case. That's not what we see.
Or on a collision course with surgery.
That's you don't need to go that route right away. Yeah.
So I mean, there are specifically said movements and there's education, there's movements, there's techniques, things that we're going to do in a combination of combining the disciplines that the way we do it may be different than what you've seen in the past. And if you've had a bad experience somewhere and said, oh no, they may be worse, or pain went further down the leg, or I couldn't move afterwards, well, then that's wrong. You should not feel worse afterwards. You should feel like whatever your treatment is, like you're getting things to resolve, back from the most distal part, or the furthest away, like back up, or the most distal here, like back up. And then if you can do that within the first, visit or two, you've got a great prognosis of getting this thing resolved conservatively.
Yes.
But you got to give that a chance and do the things at home that we're talking about and see if it's going to see the consistent movement.
Yes.
What we don't want is just the bed rest or the sitting and doing nothing forever, and hopefully get you off the medication, get you past the fear of this thing lasting forever, the fear of what should I do, what shouldn't I do, what do I even have, how am I going to fix this thing? So that's what we want to talk about. That's the model is great.
I think that hits the model helps. I think a visual is good for everybody. So
okay, cool. So those who have this kind of thing, or even if you don't know if you have, if you're just wondering or you have a question like I have this back, or a lot of times it'll be like hip, right? You don't even have to, this too, the person we saw the other day, you don't even have to have like pain up in the back.
Yeah,
you could just have calf pain, or just have hamstring pain, or even just have like heel or foot pain, and it can still be coming from the low back. But you got to get assessed properly, or then it won't get better. I mean, I had a guy today that I'm seeing from in where was he at? Norfolk, Nebraska. So he's a little ways away. He's not able to come in, so I saw him virtually. But this guy had a surgery after a work accident on the shoulder, because he said I was pulling something. I could feel this pain, like in my arm and shoulder. Well, of course, they just looked at the shoulder and did a little surgery in there. And how did you feel after the surgery? Not only was he not better, he was actually worse. But his symptoms are like shoulder, yes, but then kind of the side of the neck. And down the back here to his elbow, and then some pinky, like he feels like coldness and different symptoms in that. Well, that's a specific that's a specific lower, root in the neck around the C8, meaning that his whole now I'm not sure yet. I've only had a chance to work with him just the one time, but it's a chance that the reason he's not any better after the surgery, in fact a little worse, is because the area that they were looking in wasn't even the correct area. I mean, it's just not the correct area. So just be aware, be cautious. Make sure you ask lots of questions, and take control. Be proactive with your care. Yeah, don't just say if someone says suggest surgery off the. Get your options and
try all.
Yeah,
try different things before you go that surgical route.
And of the like we said, of the 10 people that we're talking to right now that have this, 8 or 9 of you will be fine without it, and
sure.
1 may need it. So that's what we're saying. Like, just bet down the 90%, not the 10% more than likely. So
definitely.
Okay.
Cool. Thanks, guys. Thanks for watching. Holler at us if you have any questions.